I am Ann Curtis from the University at Buffalo in Buffalo, New York, and I am here at the International Academy of Cardiology meeting in Boston. I had the opportunity today to talk about the BLOCK-HF study and the clinical outcomes associated with it. BLOCK-HF was a large, randomized, multicenter clinical trial that investigated the use of biventricular pacing compared with right ventricular pacing in patients with left ventricular dysfunction and atrioventricular block. The main trial found that when we looked at a composite endpoint of mortality, heart failure-related urgent care, and a significant increase in LV end systolic volume index as defined by at least a 15% increase, that outcomes were better with biventricular pacing than they were with right ventricular pacing. For the talk I gave today, I looked at clinical outcomes associated with biventricular versus right ventricular pacing. So in the patients that were randomized to each, we looked at three different components for clinical outcomes. One was the Packer Clinical Composite Score that includes symptoms and a variety of outcomes such as New York Heart Association class. In addition to that, we looked at New York Heart Association class specifically. And finally, we looked at quality of life as measured by the Minnesota Living with Heart Failure questionnaire. For the Packer Clinical Composite Score, we found that at all endpoints after randomization at 6, 12, 18, and 24 months, outcomes were better with biventricular pacing than they were with right ventricular pacing. For New York Heart Association class, there was a significant difference in favor of biventricular pacing at 12 months, and for quality of life, we found significant differences at 6 and 12 months. So what we found with BLOCK-HF was that important clinical outcomes for patients were improved with biventricular pacing compared to right ventricular pacing, and in conjunction with the hard clinical endpoints we found in respect to mortality as well as heart failure, that outcomes are better with biventricular pacing. All of these have led to a change in the guidelines for managing patients with these problems to include biventricular pacing as at least a Class 2A and in some cases a Class 1 indication for biventricular pacing in patients with AV block and heart failure.